Now we're going to do the Whipple's disease. So this is basically multi-system disease. Patient presents with fever, lymphadenopathy, arthralgia. Patient has weight loss, malabsorption, chronic diarrhea. Okay. We do the duodenal biopsy. We see the acid periodic acid shift positive macrophages with characteristic bacillus over there. So basically, it is happening due to the Trephorema vipelli. It happens in any age. It affects white men commonly, and it also happens in the fifth and sixth decade of life as well. Infection source is unknown. Human to human spread is not present. Clinical features: patient mostly presents with arthralgia, diarrhea, abdominal pain, weight loss. Four things, right? Arthralgia is very much important in this disease, okay? And it is basically a migratory, non-deforming arthritis. 80% of the patient they present with it. And this is the first symptom, guys. Arthritis, and patient has diarrhea. GI patient has about 75% of the cases they have pain, abdomen, diarrhea, malabsorption with distension, all the features of malabsorption, that is steatorrhea, weight loss, and patient, yes, on the patient they have loss of protein due to intestinal lymphatic involvement. Here patient has protein losing enteropathy with hypoalbuminemia and edema, all the features of malabsorption, etc. So clinical features: patient have hypotension. It is a late finding basically. Low grade fever, yes, this is constitutional features. And yes, stable, yes, we read already all the features that written over there. This is there. Lymphadenopathy patient has, yeah, this is also important thing here. Catch up point is here: lymphadenopathy and arthralgia of in the Whipple's disease. Right, heart murmurs due to the valvular important is evident. Heart murmur is heart involvement, bone involvement, lymphadenopathy, malabsorption. Now, joint involvement with large involved peripheral edema can also be present. Now, brains is also involved here. Hyperpigmentation on sun exposed CTR is also. So these are very much important points. So different things. So I will again repeat, like first of all, malabsorption. Yes, we know the malabsorption syndrome. Along with that, arthralgia or arthritis, that is migratory one. And number two, patient is present with lymphadenopathy, less hard, and we have murmurs over there, brain involvement, and patient has skin involvement, that is hyperpigmentation over there. So labs, patient has features of all, all we have read it. What was that? I will repeat it. What was that? Yes, here patient has right, yes, no need of revising that. All right, now next is just a minute, guys. Okay, now histological evidence, and what is that? We do endoscopic biopsy of the duodenum here, just like celiac disease. Okay, so we see infiltration of the lamina propria with the PAS positive macrophages. Okay, and we see the gram positive bacilli over there, right? This is the thing, nothing else. And we do the PCR sometimes. We see vipelli over there. Okay, and we can get by the duodenal biopsy or extraintestinal fluids. We like this brain because it goes to the brain and synovium, and lymph node and synovium, endocarditis, etc. Sensitive is definitely PCR is like so much good, and specificity is also very much good. Sometimes there's asymptomatic CNS infection, about 40% of the patients. So we do that PCR of that T vipelli over there, right? Differential, all malabsorption is leave no treatment. Antibiotics result in dramatic clinical improvement, and we have to give for the several weeks. Even patient with the neurological symptoms for I think so several months we have to give. So response happens in 1 to 3 months complete, one third has the relapse, and the drugs which cross blood-brain barrier, these are preferred. And what are these drugs? Yes, take the inhalation by IV ceftriaxone or Exon, okay, twice daily, or meropenem IV thrice daily. Okay, or it is followed by trimethoprim, like Septron for 12 months. Guys, we just cram this. This is a question, have asked question. IV ceftriaxone, that is IV, okay, or meropenem we give three times a day for only 2 weeks. Then Septron is given for 12 months, okay. After treatment, when we have done the 1 year treatment, we repeat the biopsy to these patients, and every 6 months they say at least 1 year after that treatment, every 6 months or after 1 year, because the recurrence can also happen. Past negative material. Uh, Low likelihood of clinical relapse. So when this is negative, then low risk. Untreated patient, it can become so much fatal, and neurological damage is sometimes so much permanent. So we have to closely monitor the patient. Okay, so this is all about it.